Hey James, how's it going?
Good, thanks. Yourself?
Yeah, pretty good. And that's exactly how my room looked like when I was studying as well.
Oh, mate, your situational awareness on point.
I remember I had this pile of notes that was just it was a sign of pride about how many SAQs I wrote out. Like if I could stack it up to a meter high, that was like my
I love
best line.
that. Yeah.
You're my first guinea pig for this, so that's pretty interesting.
Excellent.
Yeah.
It's good. It sounds like a good initiative, although I'll reserve my judgment.
Yeah, that's right. After you get all the hecklers and trolls on YouTube, which happens.
I can join the queue, mate.
That's right. So I might as well get started. Hi, everyone. This is Lahiri from ABCs of Anaesthesia, and today's a very special episode because right now I'm going to go through a Viva with one of our trainees from Tasmania who's very kindly offered to be part of this, where I'll just ask some questions and we'll have a bit of a chat. His name's James, and he was part of the Viva bootcamp maybe about a week ago or so. And this special episode will be me recording this as a podcast and for the YouTube channel as well. So the podcast is ABCs of Anaesthesia, and the YouTube channel is of the same name. And yeah, hopefully this will be useful to show how you can talk through situations, as well as giving some interesting knowledge about these very advanced, I'd say these are very advanced anesthetic topics as well, and how, I guess, consultants or senior trainees think about this stuff. Welcome, James. How are you going?
Hey, Lahiri. Thanks so much for having me. I've been looking forward to catching up and
yeah, sounds good.
whose turn?
Absolutely. Yeah, tell us a bit about yourself. So you're in Tasmania.
So fourth year trainee down in Hobart at the moment, but been part of the Tasmanian anaesthetic training program. So I've done a tour of duty around the state.
Oh, nice.
Penny and Lonnie before this, and just in the thick of exams at the moment.
And how is it going? Is it? I remember it was pretty stressful for me. How's it going with your prep?
Yeah, for sure. It's a stressful time. Although I think we're constantly getting exposed to people who are in much more stressful situations than us at work as well, which kind of puts it into perspective. So
that's so true.
I'm a lot about it.
Isn't it great? It's one of those weird accidents of being medicine that almost everyone you meet is doing worse than you. They're unwell. They're sick. So you just have to have perspective with that. Yeah, it'd be far. This is an interesting thought experiment. It'd be far worse if we were in an environment where everyone was doing, well in every other circumstance, and all we had to do was compare ourselves to that. Because what do they say? Happiness is having more than your neighbor, isn't that right, or something like that?
Yeah, and not having a fence dispute, I think.
Yeah, exactly. Not having a fence dispute. Yeah, nice one. So why don't we get cracking? So what I thought I might do is I'll just type this stem into the chat so you've got it there, and give you a bit of time. But feel free to talk whenever you take 1 to 2 minutes. But for the audience, it's the stem of this exam or this question or the situation is you are called down to review a patient for the evening emergency list in your tertiary hospital. And so that means you've got a few theatres, you've got an ICU, so it's pretty well equipped. And if the patient is a 60-year-old female, let's say they're 70 kilograms with small bowel obstruction for laparotomy, and they look pretty unwell. So what do you want to do to manage this patient? It's a very broad question, management, meaning assessment and other things, but I'll let you think about that and we'll crack on.
Okay, so this is a patient with a high-risk surgical condition who needs emergency surgery, and my priorities in terms of management would be first to assess the patient, do a formal risk assessment for their risk of perioperative complications, given this is a major abdominal surgery, consult and optimise where appropriate, and then plan the intra and post-operative course based on the findings of my risk assessment and the current availability of theatre and surgical staff.
Yeah, good. Let's say theatre's available whenever you need it and you're down in ED now. What do you do?
Yeah, so my assessment would consist of a history examination investigation, looking at using my standard anaesthetic assessment, plus specifically focusing on this patient's symptoms and signs related to their small bowel obstruction. So I'd be particularly looking for whether they've got any features of dehydration or shock associated with volume depletion.
Let's say you get down and you see the patient, and from the end of the bed, they look really unwell. There's people running around doing stuff, and you're the senior doctor there. They're looking really unwell. What do you do?
Okay, so this is now a somewhat emergency situation, and I use my doctor's ABCDE approach initially, and rapidly assess and simultaneously manage any threats to life. Focusing on a quick airway assessment, support breathing with 100% oxygen, and then circulatory support.
And I'm going to pause there for a second. So just for the audience as well, when you're in the exam, it's very hard to get all the cues that you would normally do. And I think James would agree that as soon as you see a patient, there's either two arms. One, which is assessment of patient who's unwell, is exactly what you said, doctor's ABCD. And assessment of the patient who looks well is just history, examination, investigation. And what to you, what's the difference between those two types of assessment?
So there's a time pressure involved in the first type, I guess, which isn't in the second. And other than that, I guess there's there's a focus on early intervention and management in the unwell patient with the approach.
Sounds good. Yeah, exactly. I'm thinking I'm just going to give supportive treatment and stabilize my life-giving vital signs and things like that, rather than worrying about a diagnosis. And so you're about to tell me you're going to do a top to tail assessment. Yeah, tell me what you do for that, or ABCD assessment.
So I talk to the patient, and if they talk back, then I can assume that they've got a reasonably patent airway, assess their effort and adequacy of breathing by looking at their use of respiratory muscles, tachypnea, the pulse oximetry, and apply high flow oxygen if there's any abnormalities there, or in a patient who otherwise appears unwell, by a non-rebreather. And then from a circulation point of view,
and I'll give you the results for that. So respirators 30. They looks like to be an increased work of breathing just with increased rest rate. That's a 92%. But as you mentioned, you put them on high flow oxygen, and now they're 98% on room air. Anything else?
I'll auscultate the lungs and check the position of the trachea.
Good. That all is normal. Auscultation shows just bi-basal fine creps, but nothing too significant.
Yeah.
Keep going.
So assessment of cardiovascular includes the conscious state, central capillary refill, and heart rate and blood pressure, as well as additional information potentially from an ECG.
Great. They've got two 16-gauge IVs. Heart rate's 130. Blood pressure is 100. 2 liters of crystalloid has already been given. Patient looks very flushed. Looks pretty septic.
Yeah, okay. So in this setting, I'd give another 10 ml per kilo bolus of fluids, and noting that the patient may be relatively hypotensive despite their normal blood pressure, and is demonstrating some signs of potentially class 2 shock. Further consider the underlying cause. It sounds like sepsis. So at this point, I'd be also ensuring that the patient had received antibiotics, and considering whether they're going to need support with vasopressors, which is reasonably likely. And so allocating the role of someone to place a arterial line to facilitate titration of vasopressors. And also urine output monitoring via an IDC.
Sounds good. You get that underway. Keep going.
Yeah. So the brief neurological assessment, pupils if relevant, and checking a sugar and blood gas at this point, and then looking for an alternative diagnosis in terms of exposure and checking the temperature, which I'd anticipate to be high in this septic bowel obstruction.
Fantastic. GCS is 15. They've had a total of 10 of morphine IV given by the paramedics over the last couple of hours, and in ED. They've got quite a bit of pain, and the temperature is 39 degrees, and broad spectrum antibiotics are given. Anything else?
Yes, I'd like to see a blood gas, and specifically a lactate and pH in this circumstance, as well as electrolytes given the bowel obstruction.
Yeah, pH is, let's say the blood gas is on the way, hasn't arrived yet. Keep going. Yeah,
okay. So I'd review the patient's condition post.
What do you do for E?
Yeah, so expose the patient, looking at legs, and checking the temperature.
Yeah, good. As you look at the patient and you do assessment, you notice the weight is about 80 kilos, 150 centimeters, so the BMI is 35. They've actually got a really large goitre as well.
Right. Okay.
Now, the patient looks reasonably stable. All the vital signs are within kind of a normal range, but you're expecting to go to theatre. But now you've got this. What else do you want to assess now? What else do you want to do?
So I'd also like to assess this patient's goitre with the potential implications for our anaesthetic being airway implications, so compression of the airway. So ask them about any problems with breathing, stridor, inability to lie flat usually, and assessment including the relative mobility of the mass, whether they've got a positive Pemberton sign and whether they've got any evidence of stridor, and then considering whether there's been recent imaging of their neck to demonstrate any tracheal compression if present, and as well as thinking about the potential endocrine manifestations of an abnormal thyroid, and whether that's contributed to this patient's current presentation or abnormal cardiovascular features, I guess. Yeah. So yes, sending off some thyroid tests.
And you send off the thyroid function tests. You ask the patient, no positional symptoms, no stridor, Pemberton's negative, and you look, and you do find that there's a CT scan and an ultrasound available, and that shows that there's no real retrosternal extension and no mass effect from this tumor.
Right. Okay.
Good. So what do you do now?
It sounds like we've done a reasonable assessment of the patient, and I'd formally calculate their risk.
Actually, I just want to say, so James, so what James did there, essentially, this is a really, really complex patient. You've got someone who's septic and unwell, and which you've stabilized, and you've got this goitre. So what I feel James has done is he's done what most anaesthetists do normally, which is do an anaesthetic assessment, but he's also then targeted each real difficult problem separately in an organized fashion. So unwell equals deteriorating patient management, supportive management, get them stable. And then, oh, yep, there's a goitre. Now I've got a whole other bundle of things. And this bundle includes what you mentioned, which is, other euthyroid, check their thyroid function status, and is any mass effect, which is respiratory and cardiac problems. And then finally, the diagnosis that sometimes you want to know is, we want to know is malignancy as well. So that was a very succinct way of identifying what you want without saying too much extra stuff. So that was really good, James. And now keep going.
Yeah, so a formal risk assessment with the surgeons about their plan and whether a senior surgeon has been consulted and involved, and considering whether there's anything else we can do to optimise this patient, in particular probably electrolyte replacement, given that it sounds like their vital signs have stabilised, and start thinking about preparing for the anaesthetic, so contacting the theatre coordinator, preparing the surgical staff and communicating with my anaesthetic nurse, and then also considering post-operative disposition for this patient, which would be based on a formal risk assessment as well as their intraoperative course, but given the features of septic shock that were present, potentially present previously, they may need ICU post-op, so giving ICU a heads up.
And you mentioned risk assessment. How do you do a risk assessment on this patient?
So I use the ANZCA risk calculator, noting that it usually slightly overcalls risk in the Australian context, but there's also I think the NELA or NELO database, National Laparotomy Audit from the UK, which is very cool.
James, I might be wrong, but I've heard that the ANZCA database undercalls mortality and morbidity, whereas Lee's revised cardiac risk indices overestimates. But we'll check that. You could be right.
Yeah, thanks for pulling me up on that.
No, that's right. Is that right, or?
Well, we could double check.
We can double check. Yeah, we'll double check. Good. That's what I use. So that for everyone kind of listening and watching, that's risk calculator, RISK calculator.facs.org, and that's where a really useful link to a whole bunch of a big database that you just plug in a whole bunch of values, including the surgery and demographic data for the patient, how unwell they are, and various various other parameters, and it gives you a really comprehensive readout. So that's riskcalculator.facs.org. And it's mentioned in the most recent, the 2014 ACC AHA guidelines, and I'll put a link to that. Good. So look, on your anesthetic history, you also find out that the patient's a heavy smoker, Crury COPD, multiple presentations to ED with bronchitis, and irregular puffer use. Patient has no GP, normal looking airway. And when you examine them, sorry, I mentioned bibasal crackles, but they've actually got a bit of wheeze. So I made a bit of a mistake there. So exam shows wheeze across the lungs. What do you want to do?
Yeah, so for this emergency procedure, optimization of their COPD would, with wheeze, would include administration of salbutamol via a spacer or nebulizer.
Yep. Great, you do that, and you're up in theatre now. You have everything at your disposal. After that neb that you give, the patient's still wheezy. What do you do?
So I'd give ipratropium bromide, 500 mics via a neb.
Still wheezy? What do you do?
So consider an alternative differential, or the fact that this may just be an irreversible airway obstruction, which is not going to resolve, noting the patient's had significant fluid resuscitation and may have some underlying cardiac dysfunction. But given we're about to administer positive pressure ventilation, if they were oxygenating well, then I'd consider proceeding, just bearing in mind that they may be at increased risk of intraoperative bronchospasm, and have additional agents such as magnesium and adrenaline available to manage this if required, as well as planning to use a volatile anaesthetic agent.
That's good. I guess what I'm getting at is how much salbutamol and how much time would you take to delay getting the wheezes under control before you crack on with your induction?
It's hard to give you an exact minutes answer, but I wouldn't wait for a prolonged period of time. It would be in the realm of however long it took to administer the salbutamol and the ipratropium and assess for effect, which I imagine would be probably 15 minutes.
Great. How many doses could you give in that time, and how many would you give, do you reckon?
So you could repeat the dose every 5 minutes. But I reckon I would probably just give one of each, and if there wasn't significant improvement, given that the patient has these other issues, and that with COPD often there is a mainly irreversible component, I'd probably just proceed. Well, I would.
Sounds good. And that's good. This is one of those questions where really I just want you to make a decision, and you've successfully done that. It is amazing because many trainees get into this problem, I guess, where they're thinking, oh, do I crack on with something as active as a wheeze? That's very bad. But I've also got an emergency patient. This is the classic damned if you do, damned if you don't situation. And so the only way I can really talk around it is using words like, look, this is exactly what you said, really. There's an emergency. I need to progress forward. I would take the time to give, repeated doses over the next 10 to 15 minutes as I'm putting lines in and doing all my other organizational things. And so I made all reasonable attempts to optimize this wheeze as best as possible, understanding that they already, like you said, have a component of bronchospasm that's irreversible because they've got COPD probably. So that way I'm moving forward with this and I'm just doing the best I can, which is very real. So that was good. So now you've mentioned a lot of your setup as well. So I'll just rehash that you have 2 drips, you've got an outline. What do you do? What's your plan for induction and the operation?
Yeah, so this patient needs a general anaesthetic with an endotracheal tube, and my induction plan would be for a rapid sequence induction with cricoid pressure, noting the potential for hemodynamic instability, and so having a metaraminol infusion connected and running using titrated propofol, so not a prefix dose, using 3 mics per kilo of fentanyl and using 1.2 milligrams per kilogram of rocuronium, with a plan in this patient to also gently ventilate, aiming for peak pressures less than 20 centimetres of water, noting the history of COPD and likelihood of significant desaturation on induction. That would be induction. Maintenance would be with volatile anaesthesia. I'd give goal-directed fluid therapy based on their pulse pressure variation on their arterial line and assessment of output, as well as their blood pressure, and consider a central venous line if there was significant hemodynamic instability or high pressure requirements. Ensure the patient has already had antibiotics, monitor with 30-minute blood gases initially, and then further depending on their stability, and monitor for bleeding from the surgical wound. Consider my post-operative pain strategy intraoperatively, and then depending on the progress of the patient, considering post-op disposition, noting that given this patient's COPD and pre-op state, I think HDU would be warranted, and I'd discuss the case with them prior to extubating, but I would be planning to extubate depending on the patient's condition.
So you do induction, you do rapid sequence, you give propofol, fentanyl, and rocuronium at a big dose. What do you expect on induction?
So I expect there to be some loss of afterload and preload, resulting in some element of hypotension. Yeah.
Do you normally run inotropes or vasopressors as you're doing the induction, or? Yes.
Yeah, I would for this patient. So do I normally? No. And yeah, that's why I'm running it for this patient.
Yeah. Good. Okay, let's say on induction, the blood pressure falls to 70 millimeters mercury. What do you do?
So I'd confirm the reading by checking for a pulse, looking at the height of the transducer,
yep.
And then I would temporise the situation by giving a 1 milligram bolus of metaraminol and tilting the patient head down, while doing a quick scan of the monitor, doing a quick A to E assessment, and notifying the surgeons that had significant hypotension. They may not be in the room at this point, but and as well as letting my anaesthetic assistant know that I may need assistance from them shortly.
Yeah, good. Let's say the blood pressure goes back up to about 85, 90, but then in the next couple of minutes falls back to about 70. What do you do?
So, and my metaraminol, I'd increase my metaraminol infusion. So I'd probably start it at 5 milligrams per hour and double it at this point. I'd give a 250 ml bolus of crystalloid, and then working through my A to E approach, I would first turn to 100% oxygen, manually ventilate, looking at the chest rise and fall, auscultating to exclude a pneumothorax, looking at the neck veins and the trachea midline. From a circulation point of view, at this point, I'd review the heart rate. And
auscultate the lungs is another thing that's more likely that you're trying to rule out than a pneumothorax?
Yeah, so in the setting of bronchospasm, there's potential for dynamic hyperinflation as well. So I guess just severe wheeze would make me review the ventilation settings and consider an intermittent disconnection, as this may be contributing to the patient's state. If there's also significant wheeze, that may point towards anaphylaxis as a differential in this patient.
Sounds good. And what do you think is most likely? There's no extra wheeze. It's very mild wheeze still present. Otherwise, no other signs of tracheal deviation or absence of breath sounds. What do you think is most likely?
I think in this patient, the most likely cause of significant hypotension is just sepsis and hypovolemia associated with their bowel obstruction. So my treatment would be aimed at restoring blood volume and vasopressor support initially, but dynamic hyperinflation is a concern, so I would be evaluating the plateau or peak pressures required to ventilate, and if there was high ventilation pressures, then I'd do an intermittent disconnection.
That's good.
Low to light aeration.
So that was really good. So just to feedback on that. So the structures that James did then, which I found really helpful, is in some of my lectures, I'll go through the 4 phases. So essentially phase 1 is safety, and he's gone through a process of just checking his readings, making sure that they're accurate. And then, you wouldn't need help for this as an advanced trainee. So, calling for, but mentioning to the surgeons as well is useful in terms of that first phase of just getting everything safe and checking your reading. But then you've gone into a temporization phase. You've given a bit of metaraminol, a bit of fluid, legs up, and then you're going straight away to diagnosis. And your perceptions were right. Like, this is essentially most likely sepsis, but you do a few things to rule out other more serious things that could happen: anaphylaxis, severe bronchospasm, gas trapping, and maybe even pneumothorax. So your probability gamut was right, and that's exactly what's happened here. So say with your management, you've given fluids, your aramines now at 10 milligrams an hour, and that seems appropriate for the septic patient. The wheeze is actually resolved with increased bronchodilator that you've been administering. So the wheeze is resolved. Chest, the ventilation is great. You're ventilating with 25 centimeters of water for normal tidal volumes in the normal rest rate. So everything recovers. Now, see, an hour into the operation, it is a difficult operation, lots of adhesions. And 40 minutes to an hour into the operation, you notice the temperature is now 40. What do you think is happening? What do you do?
So what do I think is happening? The most likely diagnosis is worsening sepsis, but differentials would include other hypermetabolic conditions such as MH, neuromuscular neuroleptic malignant syndrome, serotonin syndrome, and is there any other cause of hypothermia?
Oh, there definitely is.
Due to error. Sorry, what was that?
I was about to say, yeah, there definitely is. You're definitely down the right track with that one. But which one am I thinking?
Yeah, and so they're my major concerns at this point. And what I would do is, so I'd start actively cooling the patient. So this would ensure that I wasn't warming the patient with a bear hugger and turning it on to the lowest setting. I would.
You mentioned these differentials. How do you rule them out?
So I could look for rigidity from an MH point of view.
There's no rigidity. Anything else with MH?
Other things would include urinary changes, if there's a tachycardia or elevation in the end-tidal CO2.
Good. End-tidal CO2 is 30 with ventilation of 6 liters per minute. So it's in the realms of pretty normal. Blood pressure has risen. So you've now done a similar thing. You've scanned your monitors and you're checking the readings as well. And the blood pressure has risen to 150 on 100 and the heart rate is 150.
Right. Okay. So the patient is now mildly hypertensive and has a significant tachycardia as well as being hypothermic. And I would also like to check the oxygenation at this point.
Oxygenation is good.
Okay, that's great. And the rhythm, so is it sinus versus some other rhythm?
Good. It is sinus rhythm. It's just the sinus tachy at 150.
Yeah.
Now, only because this is a viva and you can't see the patient right there. Think of the case, and is there another differential that you really want to rule out? You mentioned serotonin syndrome. You can rule that pretty easily.
But of course, yes. So this patient has a goitre.
That's right.
So they may be hyperthyroid.
Great. You get a call back from the lab. The TFT results are high T3 and high T4. TSH is low. What do you make of that picture?
Can I just, so TSH was low, high T3 and T4. Is that correct?
Yes.
Yeah. So this is consistent with uncontrolled hyperthyroidism. And this together with the current situation is concerning for thyroid storm. So
that's good. What is thyroid storm?
So it is hyperthyroidism associated with significant systemic manifestations. Often it's cardiovascular, such as tachyarrhythmias, AF, heart failure, but it can be other organ dysfunction as well, liver, renal dysfunction, central nervous system dysfunction, and in this case, the hypothermia is also potentially contributing.
Yeah, good. So yeah, life-threatening exacerbation or decompensation of pre-existing hypothyroid state. And it's a clinical diagnosis based on fever, tachycardia, tachypnea, and other signs in the awake patient. So what do you do for this patient? What's the treatment?
So
first of all, actually, have you ever had a thyroid storm case and tried to treat it?
I've seen one in ICU previously as a medical student a while ago.
Okay, yeah, I've never seen one, so this is all talking in theory. unfortunately. But yeah, please go ahead.
Yeah, so there's supportive therapy, which the mainstay of which is cooling, beta blockades, paracetamol, and then anti-thyroid therapy, noting that the beta blocker of choice is propranolol due to the decreased conversion of T4 to T3.
Before we go on with that, how do you feel about beta blocking a septic patient?
Yeah, there is a risk of precipitating cardiovascular instability, and so ideally you do it with a short-acting agent initially to assess the response, but noting that to maintain cardiac output, this patient may well need a reduced heart rate, so it may be beneficial in this setting.
Yeah, sounds good. Keep going with the treatment. What other treatments are available?
Yeah, so anti-thyroid therapy, propyl thiouracil, is typically first line in thyroid storm because of the decreased peripheral conversion of T4 to T3, as well as the decreased production. Carbimazole can be used down the line, and then occasionally Lugol's iodine is used, and steroids are usually recommended as well in the acute phase because of the decreased conversion of T4 to T3. Similarly, they need adequate hydration and potentially ICU care, often ICU care, to manage the systemic manifestations as well as endocrinology involvement.
Excellent. Can you give carbimazole IV, or do you have to have them wake up first?
I don't know.
Yeah, good. There is an IV equivalent called methimazole, which you can give IV.
Right. Okay.
Good. But anyway, that was good as a framework. So I've got supportive treatment and then actual medical treatments. Supportive being what you mentioned, cool patient hydration. I've also got here just oxygen and ventilation. And then you've got a whole bunch of stuff for thyroid, which is reduction of synthesis, reduction of peripheral conversion, and decrease the metabolic effects. And some of these medications span all three categories. So when I'm thinking about this, I didn't really worry about each of those three categories separately, because that just feels like it's too much brain power. And practically speaking, what do? I just give steroids. I give the anti-iodine type things, and then I give the methimazole, and I give the propyl thiouracil and beta blocker. So really just these 5 medical treatments that I can list off. And hopefully if asked, I will have memorized some of these doses, even though I would have not given them in my, not many people would have given them in anesthetic practice. And how do you feel about this? Obviously, beta blockers are a bit of a concern in this patient. Any other reasons why beta blockers would be a concern in this patient?
So the history of COPD.
Sounds good.
Yeah.
At the end of the surgery, you notice a red mark on the cornea where you tape the eyes, but due to the proptosis, the eyes didn't close correctly. So what do? Got a bit of a red mark. Looks like a bit of a graze.
I would carefully document and then provide initial first aid. So I think in this situation, at the very least, a lubricating eye drop, but maybe some Chlorcig ointment as well, and then with a plan to have the patient reviewed by ophthalmology and to proceed with open disclosure and ongoing management depending on the sequelae.
Mm-hmm. Anything else besides what you've said there for the overall management?
We've got a red mark on specific to the eye, or just
holistic.
Holistic. Okay, so this is the patient with thyroid storm and sepsis for the laparotomy. So,
sorry, it is about the eye lesion.
Yeah, it is about the eye. Yeah, right. Additional thoughts. So nothing's coming to mind.
Anytime you get a complication, what else do you need to do besides manage the complication medically? You mentioned open disclosure.
Yeah.
And I'd like to give this as a bundle.
Okay.
Yeah.
And refer it to the M&M, put in an incident report, and talk to my MBA.
Yeah, that's pretty good. Reporting, Riskman, M&M, open disclosure, indemnity insurance. That's, what is that? The
right. Yeah. Okay.
The 5-pronged attack of safety and risk management and everything.
Right.
Yeah. Good. again, so as we've gone through this Viva, I've just been hitting you with clinical after clinical. Then we've done, crisis management, and then the crisis management just stopped abruptly, and suddenly you've woken a patient up. They got a bit of a graze on the eye. You just saved a life in theatre, and now I'm asking you about, reporting and risk man and stuff. But that's the way. This is an exam of everything, really. So yeah, that's right. Okay. No, that's pretty good. So we'll end it there. That's a good part of. I think that's been about 40 minutes. That's about right. Yeah,
Wow.
good. How'd you think you went, James?
Okay. Room for improvement. Significant room for improvement.
Look, I was really happy with how you went. So, and you can't really sell yourself, but I think you did really well in that. Yeah, to give you feedback, like. I think I've given you feedback along the way, but like your structures are sound. From the top, when I ask someone for ADE assessment and management, I want them to be able to rattle off things. I think you get away a lot in this exam by saying things quickly because you just move through very quickly. So having rehearsed answers for literally what do I do to assess and optimize A, B, C, D, E, and I'm sure I've got a.
Slow, wasn't it?
What was that? Sorry.
That was probably a little bit slow in general. Would you say?
Oh, look, it was a good speed. If you can get that faster, fantastic. And I've got a video on the deteriorating patient and optimization, which you can kind of anyone really, whether you're an intern or resident or anesthesia, you can rehearse these things. Things like being able to for breathing rates, RATES is one thing. The ARC, ALS programs, that's what we use. So respiratory rate, auscultation, tracheal deviation or tug, effort, and SATs. It's a really easy way of just listing some of the core stuff about breathing assessment. But yeah, I thought you went through it pretty fast. And as you can see, the essence of this was, you have to go top to tail, because once you say for E exposure, I do, exposure to the whole patient, obviously you'll notice a large goiter, but let's say you really had to look for a rash or something, there's always some clue. And in this particular thing, it was the goiter that was standing out once you've done the top to tail assessment. I mentioned that you did the A to E well, and then you did the goiter specific history and assessment well. You optimized the bronchospasm or wheeze before the induction. And then we did your induction was absolutely fine. The blood pressure fell. That's right. A lot of this exam, as I mentioned in my course, if you get to an arrest, it's a protocolized thing. So it's actually pretty easy, doesn't separate candidates too much, but then you're just managing small changes. The blood pressure drops to 70, not 20, but it re-drops to 70. What do you do?
Yeah. And
how do you manage these very small changes? And as you know, it's almost like you just try to be in that moment to do what you normally would do, because that's probably realistic enough. There'll be a variability amongst most people what they do, but you just do something realistic that you do in real life, and that's the answer. I like that you went to some of the weird and wonderful things when the temperature rose to 40, MH, neuroleptic malignant syndrome or NMS, and serotonin syndrome. The next level is I would rule these out by end-tidal CO2 rigidity, tachycardia, tachypnea, or whatever. And then I rule out MH straight away. Serotonin, look for the serotonergic drugs, rule them out. And neuroleptic malignant syndrome is dopaminergically acting agents, rule those out. But in this one, it was thyroid storm, and I offered you the TFT results. And then we managed thyroid storm, as we mentioned, supportive, and then medical. And finally, anytime you get a complication, you manage the complication, then report risk man opened. We should make a mnemonic for that.
Yeah, for sure.
Yeah. If any of the listeners or viewers have any mnemonics for all the administrative stuff that you have to do around an error, please share it with us. But that's good. Let's. I guess we can wrap it there. Any questions before we close off?
No. Thanks so much for running it.
Okay, good. Let's wrap it up there. Thanks very much for listening and watching. This is ABCs of Anaesthesia, and we'll just keep uploading a few more of these Viva style videos and podcasts where I'll actually be going through with someone else, having a discussion. Hopefully, you can take away what it's like to have this questioning process. Like it's not really adversarial. It's just exploring issues, and you'll find that so many people have really interesting ways of approaching things that we can learn from. And hopefully, there's a lot of good knowledge and techniques that we get out of this as well. So thanks very much, and see you guys next time.